So good morning everyone. I'm audible? Am I audible otherwise? Am I audible otherwise? Okay, perfect, great. So this session is about assessment of clinical and practical skills. This is the last main session of today. Ana pachi, once this session is over, then we are mainly doing group work, the remaining group work. So before we begin, we have taught you, or we have, I should not honestly be saying taught you, but we discussed, or there were sessions on day 1 and day 2. So day 1 began with pre-test. You wrote in on a form, what was your already existing baseline knowledge of medical education. That was then followed by Chetna Desai ma'am's lecture on goals, roles and competencies. Then we know that National Medical Commission is envisioning a particular kind of healthcare. For that, we need a competent Indian medical graduate, and for that person to have 5 roles, right? A professional, lifelong learner, leader, a clinician. So those roles, and in order to achieve those roles, there are competencies which he needs to achieve. Those competencies have already been defined by National Medical Commission and are given in competency booklets. So if you see my subject, which is surgery, so in surgery there are about 140 total competencies, right? In medicine there are many, way more than this. So for every subject, what is a competency? It is like that, it's a ability to perform a task, right? So the idea is that if the IMG achieves those competencies, then he will have those 5 roles, and then we will be able to achieve the goals. Day 1, after pre-test, Chetna ma'am talked about goals, roles and competencies. That was then followed by Anju ma'am's lecture when we talked of mainly what is andragogy, what is pedagogy. So we are into andragogy, which means adult learning. We are teaching an adult, right? 17 years ni age upar 12th is past. So when he walks to you, he is reasonably an adult. Secondly, she also talked about 3 domains of learning, which is cognitive, psychomotor and affective. On the same day, there were lectures on teaching. Okay, so day 1 we focused on what to teach, competencies and learning objectives. Learning objectives are what? Basically, you are now defining dividing the competency even further into learning objectives or statements that either are achieved at the end of that session or are not achieved. Okay, so LOs are answer to what to teach. We also then learned on the same day how to teach, in which we learned 3 things. So learning can happen for one person, few person or many. One, few or many. One person is self-directed learning. It was a session taken by Dr. Purvi ma'am in the evening. Few people, which means small group teaching, that was taken by Dr. Anuradha ma'am, small group teaching methods in the post-lunch session. And then there are many, which means large group teaching methods, which was taken by Dr. Dipali ma'am. And Dr. Paras talked about, because we are teaching a large group, you need to make them interactive so that students are still retaining interest, right? So day 1 was all about teaching knowledge or theory. Are you with me so far? What to teach and how to teach theory. You began day 2 by clinical skills teaching. So theory on day 1, clinical skills on day 2. And when we look at teaching of clinical skills, there are two main broad categories: work-based teaching and skill lab-based teaching. So work-based teaching there were two methods. One method was even demonstrated. Can anyone tell me what was that method? One method was demonstrated by Dr. Shivani ma'am. 1 minute preceptor. Okay? That method's name is 1 minute preceptor. And then she talked about for clinical skills, it is 1 minute preceptor. So in work-based clinical skills, 1 minute preceptor OMP. In work-based procedural skills is Payton's method. It had 4 stages, right? Then came skill lab. So skill lab is all the mannequins, right? Even smaller mannequins, like if there is only arm whereby somebody is doing IV cannulation vagera. Okay? So day 2 we began with teaching of clinical skills, clinical and procedural skills. Day 1 we already taught theory and we already learned how to make LOs. So one, if you see constructive alignment whereby there is learning objectives and there is learning objectives and there is teaching learning method and then there is assessment method. So in learning objectives we saw on day 1, in teaching method theory part we saw on day 1, and yesterday we saw part of the clinical and practical skills teaching. Yesterday afternoon we then started going into assessment in the more details, like what is formative assessment and what is summative assessment, what is internal assessment, right, versus what is external assessment. So, and then in the evening, because we are already talking about assessment, now we talked about assessment of theory, assessment of cognitive knowledge. So day 1 we talked about teaching cognitive knowledge. Day 2 we talked about assessing cognitive knowledge. Which was the session? The session was taken by Dr. Bhagyalakshmi ma'am. Like how would you structure a long answer question, structured essay question, how would you construct a MCQ? And we were first exposed to that, there is a lot of science to it, right? Like it is not a simple thing like you sit and you create a, you draft a question paper for an MBBS student in maybe 15 minutes, whatever comes to your mind. No. Then she also talked about blueprinting, which means that you are really trying to include most relevant syllabus. So you're not just you don't just keep on asking the same question so that the student gets 5 previous papers and is about 50-60% sorted. That 5 previous exam papers if I have, then I know that at least 50-60-70% would be asked the same. Okay? So we also Dr. Bhagyalakshmi also talked about the blueprinting. So we talked about blueprinting, we talked about how to assess theory. This session is about how to assess clinical and practical skills. So yesterday morning we learned about how to teach clinical and practical skills. In this session we are going to see how to assess clinical and practical skills. Okay? So far are you with me? Okay. Now when we talk of assessment in competency based medical education, is there, how many times have you seen Miller's pyramid on the PowerPoint slide by now? At least 3-4 times minimum, 3-4 times Miller's pyramid. Can anybody tell me what does it truly depict? What does Miller's pyramid truly mean?
Progression of knowledge and skill requirement.
Progression of knowledge and skill.
How it flows from knowledge to how to perform those things. And the more areas given to knowledge and then skill portion.
Okay. So you want to say that how it progresses, and then secondly you also want to say that more area is given to the cognitive part or the knowledge part. Okay. Anybody else? What is Miller's pyramid truly for? So Miller's pyramid suggests assessment methods. Miller's pyramid suggests assessment methods. Assessment methods are, we talked about theory assessment yesterday in the evening, LAQ, SAQ, SEQ and MCQ, right? The first two, the base and the second level. So first two levels are what? Knows and knows how. Okay? So Miller's pyramid then tells you that if you just want to assess the K level, you can go with MCQ. No deeper knowledge. You can test deeper knowledge, but it's like a very basic level. Knows how can be assessed by? So structured essay questions, right? Problem based questions, then extended matching questions or modified MCQs, modified essay, case based MCQs. When you give a case and then. Now comes the third level, which is shows how, and final level, which is perform. Okay? So this is where this lecture walks in. That if you want to assess the level which is at performance level, like you want him to independently do it without any observation, then you have to assess by work-based assessment methods, which is my part. So I will again bring you back to where what I want to say. You have assessment of knowledge or theory, which you saw yesterday. It's done. Now comes assessment of clinical and practical skills, which is this session. In this session, again, there are two parts: work-based assessment and skill lab-based assessment. Okay? So work-based assessment, which the part that I am going to take, is applied when you want to test the highest level of performance. Like, do you think that the student should know how to measure blood pressure? Yes. I mean, he does not need to do it on a mannequin. He needs to do it on real people. Right? So if you want to assess the highest level of Miller's pyramid, which is performance level, you have to apply work-based methods. And if you want to test the second level, which is shows how, then you can do away with skill lab based method. Okay? Now what is the difference between work based and skill lab based methods? Yesterday also there was a talk about work based teaching methods and skill lab based teaching methods. What is the single most important difference between the two? Perfect. Perfect. So put simply, in work based method there is a real patient. The patient is actually a patient, including the environment, of course, because if you're already dealing with patient, then probably the environment is already real. Correct? When there is not a real patient and anything else, namely there can be simulations, VR and AR, there can be mannequins, there can be standardized patients, there can be simulated patients who are actors, right? Standardized patients are, what is the difference between a standardized patient and a simulated patient?
Standardized, some expertise, so they can show the symptom sign like that.
No, they are actors, they are simulated patients. What's a standardized patient? So the patient, yes?
They are actually the patients with that type of.
But then why do we call them skill lab and not work-based assessment?
They are trained to give that specific answer or the questions.
Okay, so you are very close. So the point is that they are real patients who are right now, who have not come to you right now to show as a patient. They have come only for the assessment part or the teaching part. Like, there are many patients in orthopedics where there is a recurrent dislocation of maybe shoulder, something of that sort. Now they just don't want any treatment. They're like, I don't want to fix it, I'm fine. Then somebody calls them, okay, would you at least come to show there is something like, we need you, right? So he will happily come, he will answer, and then he will go. A stable or controlled patient of COPD, controlled, which means the disease is like reasonably okay, right? So they are also standardized patients and you can train them, okay? In fact, there are methods where professional environment, like in UK, fake patients is a known method whereby you are in your own clinic. I'm not even talking about a medical student. I'm saying that you have passed and you are in your clinic and a fake patient will come. You will not even know. He will come, get consultation done, and he will leave, and then he is going to judge you. Right? So I think this is one thing that I wanted to say. So this was a general recap of what we have done in last 2 days. Now, a couple of more questions, and then we go directly to what I want to talk about. What is the difference between a competency and a learning objective? Can anybody tell me?
Learning objective would be more specific. Competency is a broader terminology, and learning objectives are more specific, and they are formed to achieve that competency.
Right. So competency is a broader term. Learning objectives are more specific. Right. That's what you want, and they are to be achieved. Like we need to achieve them, the LOs, in order to achieve the competency. Perfect. Good. Anything else? Okay, what are the components of a specific learning objective? Which are they? They begin with STEM.
STEM, then
Audience, behavior,
content and criteria, and last one is
degree. Great. What are the characteristics of a specific learning objective?
Smart.
Which is?
Time bound.
And relevant, right? The classical example is given is a first year MBBS student narrates the steps of heart transplant. Not relevant, right? Okay. Can anybody tell me what is Bloom's taxonomy? Bloom's taxonomy. Did you hear this word ever in these 2 days?
Yes, sir.
It was spoken, okay, and it was spoken more than once. So if you did not hear it, so can anybody tell me what is Bloom's taxonomy? What is taxonomy in general? What is taxonomy? Taxonomy or taxonomy, TAXONOMY? No? So taxonomy is classification. Basically it is classification. When you are dividing things according to order, it is known as taxonomy. What is Bloom's taxonomy? So domains are defined, but what is taxonomy in domain? What did Dr. Benjamin Bloom did? Like what is he truly known for? He is known to, there's a book, okay, creating specific learning objectives. So Bloom's taxonomy and specific learning objectives. So let me just reiterate again. So after once this competency based medical education was introduced in 2019, you just want to know that competency based education, drop the medical part. Competency based education is not new. It is nothing new. It is there since almost 1960s. Secondly, એવું પણ નથી, it is not so that it is there only for higher studies like college and no. Competency based education, CBE, is also there for kindergarten students. They define their competency. The student will be able to count up to 3 at the end of this class. Do you get it? So CBE is not new. One. Okay, let's come back to Bloom's taxonomy. So what is Bloom's taxonomy? So I'll give you one example and I believe that it may clear your doubt. I'm going to talk about two specific learning objectives, okay? So one specific learning objective I'm speaking now. At the end of this demonstration, the first year MBBS student will be able to measure blood pressure of a patient in a single go with an error of 10 to 15, 10 millimeter of mercury. Now I'm telling you the second specific learning objective. It is, at the end of this demonstration, first year MBBS student will be able to measure the blood pressure of a patient with an error of 20 millimeter of mercury. Is there a difference between these two? What is the difference?
10 mmHg, that is a 20 mmHg.
10 and 20. This is the only difference. So the difference is only in the degree. Degree part of the SLO. STEM is the same, audience, behavior, criteria, condition is the same, and the degree part. Now, if you want to teach these two, do you think the methods will remain the same? And then assess them, do you think the methods will remain the same?
No, assessment will be belongs to the particular competence.
No, what I'm saying is, if you want to teach this first SLO and if you want to teach the second SLO, do you think the methods will remain the same when the change is only in the degree? They will remain the same. So they will remain the same. That is the correct answer. Okay, now why will they remain the same?
Because the content and criteria.
Content and criteria.
They are the same.
The verb is the same. The verb is the same. Verb શું છે? Measure. To measure. To measure. That is the verb. Now I give you another example that the same first competency you take at the end of the session, demonstration, first a student able to measure blood pressure, वगैरह. And secondly, at the end of this demonstration, the student will be able to enumerate 5 common causes of fever. Will the teaching method change between these two? Immediately. So everything is latched to what? The verb in the specific learning objective. Are you with me so far? Okay. So what Dr. Benjamin Bloom did was that not only did he identify the domains, which were actually identified even earlier than him, 3 domains, which is the 3 domains cognitive, psychomotor and ADCOM, but for each domain there are levels, and he identified verbs for each level. Am I making sense?
Yes.
Action verb. That if you want to test knowledge, cognitive domain, okay, and there are 6 levels in cognition, and if time permits, I'll show them to you. So for each level, he defined verbs that if you use this verb, it means you are at this level in cognition. Right? Now, if you just, after today evening, I'm not really sure if you are going to see anything related to medical education, but if at all you do, then if you just see for Bloom's taxonomy PDF simple, not the actual book, even the actual book is available, but you don't need to go in 2-3 page PDF. And people have beautifully, described those things, that cognition, 6 levels. It was created earlier. Bloom's taxonomy was created probably in somewhere in 60s. Am I right? In 60s probably? Yeah, 56. And then it was revised in 2001 by Creton. So anyways, so now are you clear what is Bloom taxonomy? That is and now if you think that the only thing that changes your specific learning objective and then changes your teaching learning method and then changes your assessment method is the verb. So that is the importance of Bloom's taxonomy. With me so far? Okay? Okay. So we saw what was done in last few days. We saw what is Miller's. We also saw so far that what is Bloom and what is specific learning objective and everything. Now we begin our session. Okay, so this was my overall outline. I'll talk about. So I think these are my the specific learning objectives or learning objectives of my session is that at the end of this, you will be able to enumerate at least 3 limitations of older or current methods. You'll be able to describe few newer methods. You'll be able to describe components of Mini-CEX, what it is we will see. And then you will be able to create a DOPS form. What that is, you will know, for the subject specific skill from a particular format. So what are the limitations of current methods? Two days. Everybody knows what are limitations of current method. The same answer. I'm not expecting any different answer. Any other? What are the limitations? Why do we need different set of assessment methods? I mean, if we already have few, right? So which are the current methods, by the way, of assessment of clinical skills? No. Methods. So some methods are subjective in nature. So one is subjectivity. By the way, subjectivity is not all bad, but let's take it for now. That's right, it is subjective. But which are the current methods? Let's first go there. No, this is clinical and practical. Long case, short case, table. Long case, short case, table. And what is there on table? Depending on the branch, there are instruments, there can be slides, there can be drugs. Okay? So what are the limitations? One is that there is insufficient objectivity. It's far more subjective. Okay, anything else? It's a snapshot. So it is snapshot only because we are not taking them frequently. So that is nothing inherent to long or short case. It is because of the schedule. So what are the other limitations? So, day 1, almost the last session Dr. Nilima took was the introduction to assessment. And there she also talked about the utility of assessment, characteristics of assessment methods. There was a equation that she had written which was into, yes, it was multiplication of 5 characteristics. If any one of them is 0, then the utility is 0. So એમાંથી બે સૌથી ઇમ્પોર્ટન્ટ વસ્તુ શું કહી હતી? Validity, reliability. Validity, reliability. Which were the other ones? Feasibility, acceptability, and educational impact. So current methods, now if you see current methods, validity, to put it at a very gross level, does it measure what it needs to measure? No. Your long case, does it measure what it is expected to measure? No. Secondly, reliability, I would say if I take a long case versus another surgeon takes a long case, will they both be similar? So not really very reliable also, right? Feasible, yes. High feasibility. All the great comfort zones that we are already in. So why to move? So there are some limitations. 5 characteristics are there, except for feasibility and acceptability. All 3 are missing. Very low validity, very low reliability, and very low educational impact, right? So these are the limitations. So that is why we needed to bring in newer methods for CBME. So which are the newer methods? So there are many, but if you want to broadly classify them, main broad categories, then they are these 3. The methods can be observation based method. Secondly, it can be chart stimulated recall, which means you are giving them something. The student is given something and then you discuss on it. There is no patient involved. It's only chart, student, and teacher. Chart stimulated recall. This is a heading, okay? This is not a method. I will talk about the method in it. And third is multi-source feedback, MSF, 360-degree feedback. It is also known as 360-degree feedback. And I think this is also something that has been talked about, okay, earlier. So first is observation-based method. So long case and short case. The long case and short case that we currently take, do you think they are observation-based method? Why are they not observation based method?
It's basically a viva. When the student presents the case, then the discussion starts. The examiner is now observing how the student is dealing with the patient. How is it?
Yeah, so very good. So the answer she gave is that when the student presents the case, the viva starts. The examiner has not seen the interaction, right? So imagine this, that when, for most clinicians this will matter more, you have a student coming in the clinics, okay? Now, when we teach them history taking, what do we teach them? And we may tell them that, today I taught them history taking of fever. Today I taught them history taking of cough or hernia or a swelling or an ulcer, something like that. But do we teach them history taking per se? Probably not. So when I teach him history taking of hernia, it's more like your first question should be this, your second question should be this. How long do you have it? Does it hurt? Did you consult anybody else? Do you have any other symptoms? So now the entire conversation, my teaching is mainly what? Cognitive. Isn't it cognitive? The same answers he could easily get from the books, that what things are needed to be asked. Am I making sense? Do you think where I'm going? Do you see where I'm going? I am trying to say that when we teach them, essentially that we take a class, there are 5-7 students here, and we are like, okay, Ajay, I'm going to teach you history taking of an ulcer. Where do we begin with? Kyare thayu tu? When did you get it? How did you get the ulcer? Does it hurt? Do you have diabetes? Now, all that is technically what? Cognition, knowledge. What does a real life history look like? So I am with a patient, I'm taking history, this and that, and then I'm like, there's it's a young patient, and maybe the kid who has accompanied the patient is crying a lot. What will you do? Do you think you will still continue with the examination? No, you'll be like, "Ene shant rakho, pehle ene attend kar lo." Attend to him. If he wants to go out, you take him out. Do you think we teach these deviations to our students? Like to be more humane there? So if I retract back to where I was, that if when teaching history taking, we are more going into still the cognitive domain. So we have not taught them the history taking part of it probably. And when we are assessing the long case, as she rightly put, we are assessing their judgments and their knowledge. At the most what we do is, we ask them to demonstrate a couple of signs. Especially in surgery or even in medicine, auscultate left lower zone or whatever, right? But the history taking part is never assessed. So what are observation based methods? You go in the room, the student goes in the room, and the patient comes in the room simultaneously. No free time, no pre-time is given. You are directly observing how he is behaving with the patient, what he is asking, what he is not asking, right? So they are observation based methods. What we are doing right now, even in most of our long cases and short cases, we are still at the level of checking knowledge only. There is a clinical material, namely patient here. But what are we checking? Knowledge, which could be checked where? By a simple question and answer. Okay? Am I communicating? Am I clear? So 3 main categories of newer methods. First is observation based method. Second is chart stimulated recall. And third is multi-source feedback. It is observation based method that we are going to see in detail. And in that we will see 2 parts. I told you. Clinical skill assessment and procedural skill assessment. So for clinical skill assessment, we will see something known as Mini-CEX. And for procedural skills, we will see something known as direct observation of procedural skill, DOPS. Okay? With me so far? Okay. So, and just to get those, the remaining two, because they are very short to talk about, I will talk about them. Chart stimulated recall is an umbrella term. The method that is actually used is known as case-based discussion. Do you know case-based discussion was discussed yesterday by Dr. Shivani Patel ma'am? When she was talking about teaching of clinical skills, one of the method of teaching also and one of the method of assessment is also case-based discussion. She had told us a specific indication of CBD. Where will we use CBD? Case-based discussion. Does anybody remember that? Case-based discussion. In what setting is it commonly used? Okay, what is case-based discussion? Madam had shown the photograph of a case paper. So consider, for example, that this is the case paper of the patient. Case paper. Do you understand case paper? Where we write things on? The actual case paper. Okay? So what is case-based discussion? Yesterday, madam also had shown a photograph of an indoor case.
DKA patient.
Yeah, there was something about a DKA patient. So DKA is a emergency. So what she said was that there are times, usually in emergency, where you do not have time to teach because you are there trying to treat. So what do? You allow the treatment to be done. And maybe the next day you pick up the case paper and you start from the beginning. Right? Correct? So it is, because it is like a case paper, that method is known as chart stimulated recall, because now you're going page by page. Okay, so what did the patient present with? So now you're like, okay, as the patient had complaint of abdominal pain. Okay, so what do you think can be abdominal pain in this age for? Right? And then you go to so then you ordered this investigation. Let us justify why did you order this investigation, right? Here the commitment is already done. What was to be done has already been done. The student needs to stand on his ground for why he did that, right? So the second method is chart stimulated recall with an umbrella term. The name is case-based discussion. Third is multi-source feedback. It is like you take feedback about the candidate or about the student from multiple sources. Which are multiple sources? The teacher, the patient, the patient's relatives, staff nurse, and orderlies, even the friends, even the colleague, even the canteen person. You can just take, everybody, just about everybody, right? And because it is multi-source, it's really less likely that it will go wrong. It will usually bring forth what that person truly is, right? So these two methods are out now. So now we are going to talk about observation-based method, okay? So in this observation-based method, we are going to talk about two methods, okay? Those two methods are, as I told you, two main categories: clinical skills no assessment and procedural skills assessment. Clinical skills assessment mate we have a method known as Mini-CEX. CEX stands for clinical evaluation exercise, and Mini-CEX is like a shortened version of that exercise, okay? So let's talk about that. You have been given this, the annexure list, right? Out of this, I think it is annexure 10 or 11. It's annexure 10. Annexure 10. I'm going to show it on the screen also, but you may still just want to have a look at it. Open annexure 10. Yeah? So, okay, so what is it? So the method goes something like this. A real patient encounter. Which methods am I teaching? Work-based assessment. I am teaching work-based assessment. So whenever I talk, that means I am talking real patient. Okay. Next up, Dr. Puri Bhagat ma'am will come. When she will speak of OSCE and OSPE, which are skill levels. So now let's come back. Mini-CEX. Real patient, the student and you. The history taking and clinical exam encounter takes place. You are observing. You are observing. Usually, one single Mini-CEX experience can last up to 10 to 12 minutes. It can go up to 15, no fixed time limit. But you usually do not give feedback in between. There are no interruptions in between. Of course, there are interruptions if something is going to harm the patient. That's a different thing. But otherwise, you do not give any feedback in between. You allow the encounter to complete. Okay? So one student, one patient, one observation. For that, you need to fill this form once. Okay? Clear? Okay. Now let's look at the component of the forms, and then we will talk about certain other aspects of the Mini-CEX. So it is mini clinical evaluation exercise. It is the modification of traditional bedside oral examination, series of real patients, and a doctor can judge and can take up to 20 minutes. So you can see that in the form there are, in the middle where there is a table that writes of 7 skills. Those 7s are like this. And the rating scale. So for each skill, you are going to rate them from 1 through 9. There are bunches of 3, 1 through 3, then 4, 5, 6, and 7, 8, 9. Okay? So, unsatisfactory, satisfactory, and superior. So this is the form that you have right now, right? If you see the top part, it is detailing that particular encounter, like who was the student, who was the teacher, what was the patient's diagnosis, what was the setting, whether it was in ED or whether it was in the OPD or in the ward, right? So you write all those details here. You can also define how complex the case was, right? And you can also define what is the focus of this particular encounter, okay? The second part is where you are actually rating the student, okay? And this is pretty clear that you want to see for medical interviewing skills, you want to see physical exam skills, then humanistic qualities, and overall clinical efficiency, etc. Now, besides each attribute, there is also an option called not observed. So what I may do is that I may rate a student on number 1 for 3 and number 2 for 8 or whatever, and then 3, 4, 5, 6, 7 I may say that it is not observed. Because for an examiner also it is not possible to observe on all 7 counts. And to observe and then rate all 7 counts, it may not be possible, right? So what we do is, we can safely say that these 2 attributes were not observed in this particular encounter. Okay? Right? Okay. Then comes the third part, which is where you write about how long did it last, and how satisfied is the student with it, and the teacher with it. And finally, there is any feedback. Usually, wherever Mini-CEX is done, it is done in 3 copies. Like you make 3 copies of one single encounter, 1 copy goes with the teacher, student, and 1 goes in the department as a record. So now if you think that this is one Mini-CEX, what do you think are the limitations of this method? You now know what is Mini-CEX. 1 encounter, 1 student, 1 patient, 1 examiner, 1 paper, and I want to rate him on 7 counts, fill out the other details and file it in the. So what are the time consuming? In fact, it is solving that problem. It is solving that problem because it's like 10 or 15 minutes.
You have to incorporate so many mini evaluation over the time to judge the.
Perfect. So one Mini-CEX is nothing. One Mini-CEX is nothing. Okay? And let me tell you that Mini-CEX, this particular method has been put to test, which means there are many studies about this method and efficiency of this method. Did I make sense what I want to say? That there are many studies that have evaluated this particular method. They have put this method to test. That is Mini-CEX really a good, valuable tool or not? It is one of the most studied method of assessment. So number one is that one encounter is not enough. You have to do it multiple times. I already told you you will not be able to see each and every point of the 7. So that means you are going to not observe few. So what will you do? You will observe it the next time, right? Clear? So number one is that multiple records are required. Now in ideal scenario, there has to be multiple patients, multiple settings, and multiple examiners. So now you know that if you have just one student and one examiner, I may tweak it. But consider that one student is going to be examined by all of you, 29 of you. And then there are 29 different patients. And out of them, 5 are in ward, and 10 are in ER, and 2 are in OT, and 5 are on road. Now, do you think then that student will be able to fake it anymore? It is not possible. Then you are like, nah, whatever he is, it will show up. Clear? So one encounter is not enough. Secondly, so you need multiple encounters. Second thing is that high stakes, which means emergency cases, not allowed. Okay, so this you don't do it on emergency cases, right? And high stakes, which means any skill which you think is extremely important, then Mini-CEX you may not do it like, you may not rely on it one-off. Also, you need training of the assessors. If I want to conduct a Mini-CEX, I really need to be familiar with it. And I'm like, okay, let me see how it goes. And once I do them 2 or 3 times, that is when I will realize my limitations, that I keep on observing only these 2 skills. I'm not seeing this particular skill, right? So the assessor training is also required. So the limitations are, you need multiple assessments. This is not a good method for high stakes or emergency situations. And third is, you also need assessor training, right? The strengths are trainees' performance with real patients. Real patients means work-based. Work-based assessment means the highest level in Miller's pyramid, which is perform. And feedback is provided. So it forms which kind of assessment? Formative assessment. Feedback is to be written on that paper. And feedback kayu lakhwano, we have already seen yesterday, right? It needs to be specific. The weaknesses are single encounter is not sufficient, varying scenario, different assessor. Also, there can be some difference between assessor and time constraint vagera. There are certain challenges which it does not represent very well. Mini-CEX clear? Okay? Single paper, one encounter is not enough, many are required. These Mini-CEX Association of Internal Medicine in USA, probably they had invented this technique and they have their original form. You can always modify this form, essentially keeping the central part the same, you can modify the form. Now comes the last part, which is how do you assess the procedural skills. My session is work-based assessment, level 4 of the Miller's pyramid, 2 parts, clinical skills and procedural skills. Clinical skills, we are done. There are many other methods, okay? This is not the only method. But to begin with, this is the most simple and the most trusted one. So now comes what is direct observation of procedural skills. It is essentially a cousin of Mini-CEX. No difference. The same kind of form, details on the top, rating in the middle, and feedback in the end. Okay? Details, rating, and feedback, right? So instead of clinical skill, which is history taking and examination and professionalism and humanistic values and overall performance, we are seeing procedural skills like NG tube insertion or injections or venipuncture or PUC catheterizations. Okay? So we will just see the form and you will know. So you can see that this part, the topmost part of the form, which is trainee's name and assessor name. So essentially the details. Mini-CEX also had 3 parts: the details, and then the the scoring, and then finally there was the feedback. It's the same kind of form, no major difference. Okay, the detail, and because we'll just go. Then you rate according to what? Now this is where some changes can be. So Mini-CEX is the same for every branch. So any branch of medicine, whether it is medicine or surgery or ophthalmology or gynecology, Mini-CEX form remains the same because it is about history and examination. General, it is not about whether he did a hernia examination well or not. But DOPS is specific to each procedure. So a department can sit together, and then if they think that NG tube insertion, nasogastric tube insertion is something that we want to create our own DOPS for, then you can just keep the basic skeleton of the form and then come up with these steps, what you think are required. Now you can of course source it from textbooks and stuff, but so for example this one is like, and if you see the rating scale is the same, unsatisfactory 1 through 3, 4, 5, 6 is satisfactory, 7, 8, 9 is superior, and if it is not observed then you say that power was not observed. So for example, this is like demonstrates the understanding and demonstrates understanding of indication, relevant anatomy and technique of the procedure, informed consent whether it was taken or not, appropriate pre-procedure, risk awareness, aseptic technique was there, technical abilities were there, seek help where it was not, wherever it was required. So you want to put down each step and you want to rate each step, and at the same time it is possible that you may not be able to rate everything, which goes back to that one encounter may not be enough, right? When there are so many things to observe, it is possible that you may not be able to observe all of them, and that is why with DOPS also one encounter may not be enough. You may not be able to certify on the basis of one encounter. And then of course there is specific feedback by the assessor, and there can also be trainees' comments, and it goes to the what's the future plan that you should maybe study this, or we'll conduct a demonstration or something like that. So you also decide about the plan, and then you sign it and file it. So essentially 2 methods clear, both are paper based method. Mini-CEX for clinical skills, history taking and physical examination, and also other everything that surrounds it. The second part is DOPS, which is for procedural skill. It is procedure specific, and any department can themselves also come up with their own ideas. So I think with that my session ends, but I want to bring to your notice a few things. Okay. So for last 2 days there are many newer words and newer terminologies that were used, that were sort of discussed, if not exactly taught. So I just wanted to highlight that what all of that learning did I use in creating this session. So like I did some amount of self-directed learning to prepare for this session. I also showed you some objectives before beginning my session. I also had prepared a lesson plan. Okay? Lesson plan સવારે પ્રકૃતિમાં મેં કીધું હતું, right? So like especially એનો એક part છે, lesson plan નો છેલ્લો part છે, which talks about micro planning, that there are no breakdowns. She talked to you about that, the day before the BCME started, they came here and the projector was broken, correct? So I also have written in my checklist of micro planning that I need to record. So what all do I need? I need whether my this thing iPad connects or not. So I just want to tell you that the same principles that are used, that have been told, that they have been used by most of us, including all the other faculties, to complete. Now, last thing, you have, we will do the traffic light thing. If anybody has any query, you can show a red card. If you think that concepts were clear, you may show a green card. And if you are anywhere in between, then you show yellow card. The cards are already on your table. They are pinned, so you may have to unstaple them. See, if you want to show, you have to show it like this, so I know. At day 3, this question loses its charm, because most are like, if you want to go, if we show red, then the car is going to stop. It's going to stop, and they're again going to bang it. And I'm like, no, kuch bhi karke, green karke, jaane do ise. Yeah, I mean, and it's important also, honestly relevant. Okay, so is there, and finally, before I close, so before I close, personal request, I will be sharing one link to a Google form on BCME July group, not right now, it will be for the feedback of my session. Please be honest, provide me with whatever is your feedback, okay? It's a simple form, okay? Yeah.